Nicole Superville, Mike Gibson, and we are talking about the demographics of treating patients with tafamidis and the outcomes. So therapy is only as good as, if you get it, right, Nicole? So talk to us about,
Exactly.
some of the disparities we got out there and then some of the disparities in outcomes.
Thank you so much, first of all, for having me, Dr. Gibson. And it's a pleasure to kind of talk about the world of amyloid in general, in terms of TTR amyloid specifically, given we have, a lot of new therapies for patients on the market. Of course, at the time when we looked at the study I'm going to talk about, only tafamidis treatment was available. But nonetheless, I think it gives us good insight into some of the socio-demographic disparities that may exist. So in terms of this particular study that we did, it was a retrospective cohort analysis, looking again at the socio-demographic disparities in terms of time to initiation of tafamidis, as well as clinical outcomes in a really large population across the US. We used the Komodo Health Map, and we were able to identify over 11,000 patients in terms of confirmed TTR cardiomyopathy. What we found that women unfortunately fared worse. First, in terms of time to initiation of tafamidis, we looked at patients when they were diagnosed throughout to the time of initiation. And when we stratified that by sex and race, we saw that white women actually had the lowest uptake when we looked at about the 12-month mark. Overall, I would say about 14.5% of women by a 12-month mark had been initiated on tafamidis compared to almost 30% of men. In
Wow.
addition
So,
to,
so can I
Mhm.
ask you, Nicole, how do you
Sure.
get the denominator there? I mean,
Mhm.
how do you know how many people? So you did know how many people had the diagnosis, right?
Exactly.
And
Mhm.
then you looked at how many of them were treated, I guess.
Right. Looking at
How,
claims data.
yeah, so how good
Mhm.
is and how accurate basically is that denominator and numerator?
Yeah, so that's a great question. With the Komodo Health database, it puts in, I guess, information from over 150 payers, and we're able to look at a lot of patients who take advantage of commercial, Medicare, and Medicaid. Of course, we're not necessarily capturing patients who use, for example, the patient assistance program, but it still allows us to capture quite a number of patients. And using ICD coding, of course, and claims data, we were able to feel pretty confident in terms of those we identified were patients with true ATTR-CM.
Wow. So
Sorry, go ahead.
white women had delays in
Mhm.
treatment and also were treated less often. Is that fair to say?
Yes. So I would say, and we did find that you're right, for a number of reasons. I would say, I think on a whole, we still think of ATTR-CM as a predominantly male disease, although when you look at autopsy data, that's a little different in terms of probably nearing equal proportions in some instances. So I think certainly there is some provider bias there in terms of making the diagnosis and probably wanting to confirm the diagnosis for women. Surprisingly, though, for Black women actually had a shorter time to initiation of tafamidis.
Hmm.
And I think that is because there is some advantage to that awareness of the V122I, which is commonly seen in, or prevalent rather, in African American patients. So I think, in terms of within women, looking at women, Black women surprisingly actually fared better in terms of time to initiation of the drug.
And how did white men and white or black men compare?
Yeah, so in terms of the initiation of tafamidis, white men fared much better in terms of 31% by the 12-month mark. Black men also was about 26.7%. And then, as I said, in terms of Black women, that was about roughly 22% and then 11% in terms of uptake for white women. Apart from the initiation of the drug, though, when we looked at clinical outcomes, because we also followed patients from time of diagnosis to their first cardiovascular hospitalization or death. And when we look at the clinical outcomes, interestingly, in terms of event-free survival, Black women actually fared worse
Mm,
compared to Black men, followed by white women and then white men. And
mm,
I think just looking at the overall cohort, again, you could start to see that separation of factors that actually influence access versus clinical outcomes. For clinical outcomes, for example, we saw much higher rates of comorbid conditions in terms of diabetes, CKD, and even systolic heart failure in terms of Black patients. So it seems like clinical outcomes are driven more so by comorbidities and
mm.
disease burden when you kind of parse out the data.
Now, when you look at socioeconomic status, when you look at zip code, you are
Mhm.
your zip code. Your health is your zip code. Did you find
Yeah.
anything there?
Yeah, so we did interesting that you say that, looked at the data in terms of the social deprivation index. And that's really a measure of area level deprivation, which takes in a number of factors. And of course, the higher the number, the worse the social deprivation. Interestingly, when we looked at the time to initiation of Tafamidis, the results were pretty consistent across social deprivation index. When we looked at clinical outcomes, interestingly, women with lower social deprivation actually had worse clinical outcomes. So there was some kind of paradox there.
Mm,
And one of the reasons we probably think that is because of the patient assistance program. Again, we're not capturing patients who take advantage, of that program. And so, for patients, for example, who have better social situation or socioeconomic situation, they may not necessarily access the drug. As, for
mm.
example, somebody with a higher social deprivation index that may be able to take advantage of the patient assistance program. So again, certainly maybe access may come into play there, but certainly that was one of the paradox that we saw in the data.
Wow. I mean, a lot of surprises all the way around.
Yeah.
Well, thanks so much, Nicole, for sharing with us. Very interesting. Not what I thought you would be saying. So thanks for sharing with us. And, I'm just going to tell you Nicole Superwoman. I know it's Superville, but just going with Superwoman, if that's okay. Thanks for joining us today, and thanks for educating me. I learned a lot. Thanks, Nicole.
Awesome. Well, thank you so much. Hopefully we get to see each other again while we publish more.
I hope so. Thanks, Nicole.